Okay. Is the microphone working? Everyone can hear? Okay, great. Okay, well, my name is Sally Hibbert. I'm a paediatric dentist. I work at the Children's Hospital at Westmead, but I also have a role at Westmead Hospital where part of that role is running the transition clinic. So I see both paediatric patients, but also I'm just looking around. I don't know if there's anybody here that I recognise that I may see over at the transition clinic as well. But I have to say, since I've been running the transition clinic, it has been a massive eye-opener to me, not just point of view of osteogenesis, but from all the children who are transitioned through with special needs, either physical, developmental, cognitive or medical. It really is an eye-opener and a rather scary eye-opener. I feel for exactly what you were saying in your question, that I see carers coming through in particular, literally in tears at the upheaval of leaving the Children's Hospital all under one roof and suddenly being spread across the country. And I'm hoping that with the new transitional plans at Westmead that we may be able to improve that, and it's something that I hope to be able to work on myself. But what we're talking about today are the dental implications of OI. So first of all, we're going to talk about the dental anomalies that we see in OI. What are the differences, the common differences in teeth that we see associated with OI? What are the complications of dental care? And we can't go past that without mentioning bisphosphonates. I'm going to be talking about that purely from its implications in dentistry. I'm absolutely certain that yesterday Craig Munns would have covered that in far better detail and would have explained it far better than I ever can. But we'll talk about why bisphosphonates are an issue for dental care. And finally, we're going to move on to just some general preventive dental care, which is applicable to anybody, regardless of whether you have OI. So what are the dental anomalies? What are the differences that we see in patients that have OI? Well, one is a condition called taurodontism. I'll show you an x-ray of that in a minute. Taurodontism is just an odd shape of our teeth. We see it in molar teeth. The main thing really of only interest to us as dentists that it can have implications if you need root canal therapy, because it does make it a little bit more complicated. A strange oddity is that we sometimes see that the second permanent molars in the top jaw don't come through. We don't know why, we have absolutely no idea. We don't know why it's those particular teeth, but it's something that we do see, that those teeth can remain up there. If they're not causing any harm, they can be left, but if they do start to create problems, sometimes we can get cystic change around them, then that can have implications for us if those teeth need to be removed. Depending upon the type of OI and the severity of the OI, we sometimes see that the top jaw is smaller than the bottom jaw, okay, what we call a retrognathic maxilla, and that can lead to our bite being a little bit different. That our bite is the wrong way round, and that can have implications as well for the way that our teeth particularly wear, which can be a feature. We sometimes see missing teeth. Missing teeth are more common in patients with OI. And then, of course, there's dentogenesis imperfecta, which we see so commonly associated with OI. And there's different ways that this has been classified over the years. One of the ways it was sometimes classified was talking about opalescent or hereditary opalescent dentine. But the classification as dentists that we tend to use now is dentogenesis type 1, which is associated with OI, and dentogenesis type 2, which is what we call non-syndromic. In other words, it's not associated with OI or with any other syndrome. It just appears by itself. Okay. Now, this is an example here of taurodontism. So we don't seem to have a laser pointer. No. Well, here we are. We can use this. So in taurodontism, this is a normal tooth. That's the normal proportions of a molar. In taurodontism, it's called taurodontism because it looks like bull's horns. Okay, we see that this part of the tooth, apart from the tip of the crown down to the roots, is widened, and the roots therefore proportionately get shorter, and it's considered to look like the horns of a bull, which is why it's called taurodontism. They say the only real implication for that is that it makes life a little bit more difficult for an endodontist if you need root canal therapy, but otherwise is of no particular concern. The unerupted second molars, we can see an example up here of a second molar that has failed to come through, and in this situation here, that's also going to prevent the third molar, the wisdom tooth, from coming through. So that can create a bit of a logjam up there. If it's not causing any symptoms, there is no indication to remove those teeth, but we can sometimes develop cysts, and therefore it is something that does need monitoring by a dentist. Okay. Move on to dentogenesis imperfecta. Issues of that, as far as we're concerned as dentists, and the one that I'm sure anybody here who has OI will know only too well, is the excessive chipping and wearing of teeth, which can occur pretty rapidly. Okay? Along with that, we have bulbous crowns, we have what we call pulpal obliteration. Again, we've got an x-ray of that in a minute. We also tend to see over-retained baby teeth. The baby teeth tend not to fall out in many cases. This is something that over the years, more recent years, has become a little bit confused with bisphosphonates, because we don't really know if we're seeing over-retained baby teeth now, but the child has had bisphosphonates long term, then we start to question, is this a side effect of the bisphosphonates? But even pre-bisphosphonates, we knew that baby teeth were more commonly retained, and that either can prevent the adult tooth from coming through, or it causes the adult tooth to go into an unusual position. Either way, we often have to end up removing some of the baby teeth. Okay? Probably the greatest concern, though, as far as dentists are concerned, is the excessive wearing and chipping of teeth. Okay, and that's a problem as also from a restorative viewpoint, because although in dentogenesis the actual defect in terms of the development of the dentine of the teeth, the defect is within the dentine, that defect also affects the way that our enamel, the hard white part of our teeth, joins to that dentine. So if the dentine is defective, the enamel tends to chip and break away. Okay? All the materials that have been designed over the years to stick to teeth, so in particular over the past 30, 40 years, where there's been a lot of research into designing what we call adhesive dental materials, are all designed to stick to normal enamel. Okay? If that enamel chips and breaks away, then the filling's going to go with it. Okay? So it causes a lot of problems for restorative dentists in terms of how we can restore teeth without finding that everything just starts to chip and break away over time. Okay? Here is an example of a child with what we call strip crowns on the teeth. Okay? These are little composite crowns that have been put on. Up at the top here we can see a gap. That's because these teeth have grown through a bit more since the caps were done. Oops, I'm getting a bit carried away there. Down here we can see some teeth whereby they haven't been capped, or potentially even the caps have been lost. And this is an ongoing problem, particularly with baby teeth, that we try and do our best to cap these teeth, A, to stop them wearing away, but also, very importantly, to give these children a nice smile. You know, the number of times that parents will say to me, especially as a child is getting, you know, towards around 4 or 5, they're becoming that much more noticing that they're a little bit different, and just being able to send that child off to kindy with a nice smile is terribly important. So we try and do our best to cap these teeth, but inevitably often find that they will start to chip and break, and over time we sadly often have to accept defeat, but know at least these teeth, the baby teeth at least, front ones, will be falling out at around about 6 or 7. Okay? So here we've got an example that we can see why we call it hereditary opalescent dentine, the obvious brown opalescent discoloration of the teeth. Down here we can see a classic X-ray of a child with dentogenesis imperfecta, The crowns of the teeth are much more bulbous than they should be, and we can't see any root canals. The teeth are filled in with dentine, which makes root canal therapy extremely difficult over time. Common question I often get asked when I'm seeing young children with dentogenesis, that very, very common question: will their adult teeth be affected as well? Probably by far and away one of the commonest questions. And the answer is maybe. Okay. Most of the work on this has come out of Scandinavia. All the best stuff comes out of Scandinavia. Don't ask me why, but they do some tremendous research, particularly people like Barbara Malmgren and Jonan Darloff at the Karolinska in Stockholm have come out with some really good stuff. And this is some research that came out of their team, published just a couple of years ago, where they looked at the different types of osteogenesis imperfecta and how likely it would be that if you had dentogenesis imperfecta in the primary dentition amongst baby teeth, what are the chances of having it in adult teeth as well? And in terms of totals, it was about 50%, okay, down at the bottom. Half children had it in their baby teeth, half their children had it in their baby teeth and their adult teeth, okay? With type 1, it was fairly clearly split. You had about a 50-50 chance, if you had dentogenesis with type 1 osteogenesis imperfecta, that you would also have dentogenesis imperfecta in your adult teeth. If you have type 3 osteogenesis imperfecta, you are more likely to have both of your dentitions affected. With type 4, it's the other way around. It's more common that it's just seen in the baby teeth. Okay? Here is an example, and this is an example from their research, a child with quite clear and obvious dentogenesis affecting their baby teeth. You can see how worn down they are. This is their adult dentition. Okay? And it's also interesting that in many children, even if there is evidence of dentogenesis in the adult dentition, often it's not as severe as baby teeth. I know when I was a registrar, first started my training, we would often automatically, as soon as the adult teeth started to come through, we'd start capping them and saying, oh, we've got to protect them. But we've now shown that in some cases that we do see the adult teeth starting to wear very quickly, and we do need to intervene quickly. But there are a lot of cases, and I'd say the majority, where we do not see the adult teeth wearing down to the same extent as the baby teeth. And we can therefore afford just to sit back and wait and see how it goes, okay? Intervene if we need to. But the bottom line is, sadly, we probably aren't going to know how severely the adult teeth are affected until they come through. Mm-hmm. Mm-hmm. So moving on a little bit here to what are the treatment concerns when somebody comes in who has osteogenesis imperfecta? Well, as far as dentists, probably the main concern is around extractions, okay? And general dentists will get very concerned if they see a patient with osteogenesis. There's issues with prolonged bleeding. Also, in some cases, there's hypermobility of joints, and in particular, what we call the temporomandibular joint or jaw joint, okay? And then, of course, there's the big one of bisphosphonates, okay? And I think it would be fair to say that, say, bisphosphonates to a dentist, and it'll just send them into a panic, okay? They really are quite terrified of the word bisphosphonates, and many dentists will just not treat or go near anybody that is on bisphosphonates. We'll talk about that in a couple of minutes because, yes, there are concerns, there are very serious concerns, but equally, there general dental treatment and particularly preventive dental care can be provided by general dentists, and more to the point, essentially, it must be provided to make sure that we don't move on to the problems, such as extractions, that can be problematic. Root canal therapy, that can be an issue. Especially with dentogenesis, we get pulp obliteration, the tooth anatomy, the bulbous crowns, the toroidontism. The only issue there really would be that if I had dentogenesis and I needed root canal therapy, I would be going to a specialist endodontist. That very, very sadly means a lot more expense, but at least a specialist endodontist would have more of an idea about how to do the job successfully. Okay? What about patients? What are the concerns that we have of patients? We have done some research into looking at patients in transition as a whole, their concerns as they move from childcare into adult care. And certainly those that had OI that we approached, their main concern was, I just don't think my dentist understands OI. And they were really and probably genuinely concerned that their dentist really didn't understand the issues and were they going to be appropriately managed. I think that that is an understandable concern, and certainly one of the things that I'm looking into in trying to develop our transitional services is making sure that general dentists have a really good way of gaining access back to us as specialists so that we can guide them and hopefully provide them with the information that they need to make sure that you have good and adequate treatment. The other thing that is absolutely vitally important when you visit a dentist is please, please, please make sure your dentist knows if you have received bisphosphonates or are currently receiving bisphosphonates, okay? Again, we have come across some cases with young adults where they've thought, oh, I'm not going to mention it, just causes problems, you know? Well, nothing like the problems that could potentially happen. So please do make sure that you do disclose to a dentist if you have received bisphosphonates. Which moves us on to the dreaded stuff itself that sends every dentist into a panic, okay? Bisphosphonates, and now even some of the newer, what we call anti-resorptive agents, such as denosumab or Prolia, okay? And certainly many patients that I see have very high cumulative doses of bisphosphonates that are a concern. We often say, and we repeat this frequently, that there has never, ever been a reported case anywhere, at least in the literature, of what we call medication-related osteonecrosis of the jaw, or MRONJ, ever in a child, okay? But as Professor Salence would tell you, there are many reported cases in adults. And one of the things we have to consider with bisphosphonates is that they have a very long half-life, which I'm sure Craig went into yesterday. So if you have bisphosphonates as a child, that is going to hang around in your bones for a long time. So even if you move off intravenous bisphosphonates onto oral bisphosphonates, it will still be in your bones, okay? What is it? This medication-related osteonecrosis of the jaw, it's basically a delayed healing of the bone or the tooth socket, okay? That leads to what we call necrosis or death of the bone surrounding that socket. So, in other words, if you have a tooth taken out, normally following the extraction of a tooth, the bone remodels, the body fills in that socket, the hole where the tooth was, and over time, it takes many months, you'll find that that socket will disappear and be replaced by bone. Bisphosphonates really, really slow that process down, okay, to the point that the surrounding bone in the socket becomes infected and dies, and what we call necrosis. And we can get this bone within the jawbone that just never heals. It's just a persistent infection in the jawbone, okay? There's things that we can do to try and prevent it that we'll talk about, okay? But that's really what MRONJ is. The big thing that concerns us is what we call the cumulative dose of bisphosphonates. So we have to take into account somebody who's had a lot of intravenous bisphosphonates as a child. We can look at the cumulative dose they've had over the years, and then if they've moved on to oral bisphosphonates, how that also adds to their cumulative dose, okay? Because the bisphosphonates are going to get concentrated in the bones, which is where they're doing their job to try and prevent fractures, okay? Why the jaws? Why does it affect the jaws and not elsewhere in the body? Okay. Well, the reason for that is severalfold. One reason is that the jaws or mouths are one of the few areas of our bodies where we actually have potential access for infection in that little junction between our teeth and our gums. Okay. So in there we can get a potential source of infection. So this condition of osteonecrosis doesn't just happen with taking teeth out. It can also happen spontaneously for somebody that has very, very poor gum health, or what we call periodontal disease. Okay, so this is why it's imperative that you maintain really good oral health, not just of teeth, but of gums. Otherwise, we can get spontaneous osteonecrosis due to an infection. One of the other reasons it happens in the jaws is that the jaws actually have a very high blood supply, considering that they're bones. And because of this high blood supply, the bisphosphonates tend to get concentrated within the jaws. The other thing about our jaws is the bone turnover is very high in our jaws compared to other bones. And that high turnover also leads to concentrations of bisphosphonates in the jawbone. The final reason is that the covering of our jaws, our gums, what we call the oral mucosa, tends to be quite thin, okay, compared to skin. Okay, it's not as durable either. So therefore, because of that thinness, that can also lead potentially, if that gets worn away, to again a source of infection and potentially necrosis. So there are particular reasons why our jaws more commonly would get osteonecrosis than other parts of the body. So what are the risks in terms of you getting osteonecrosis of the jaw? Okay. The really, really big one and the overriding one where we see cases of osteonecrosis of the jaws is not in people who have OI. It's in people who are receiving bisphosphonates for other reasons, okay? And predominantly that is many people who are receiving bisphosphonates as a part of their cancer therapy, okay? So that is where we see commonly or most commonly cases of osteonecrosis, okay? So you're not up there at the top. Okay, for the people who are most at risk is people who have other illnesses, particularly cancers, that are more likely to get osteonecrosis. A big one, though, is smoking. Okay, smoking seriously affects our gum health and the condition and health of our gums. So if you smoke and you're on bisphosphonates for your OI, your chances of developing spontaneous osteonecrosis are higher. Okay, so if you smoke, if you wanted another good reason to quit, okay, there's your reason. Okay, poor periodontal or gum health we've already mentioned, and also poorly fitting dentures, because poorly fitting dentures can rub away at that thin mucosa, and if it chronically rubs away at the thin mucosa, that can precipitate that area of the jawbone to get osteonecrosis. Our lower jaw is much more at risk than our top jaw. Okay, again, there's reasons for that, but the commonest place we see osteogenesis is the back of the lower, sorry, not osteogenesis, the commonest place we see osteonecrosis is the back of our lower jaws. So that's the area where it's really important that we keep everything healthy. You don't have any dentures that are rubbing away, causing sores. What many people ask is, you know, worst case scenario, if I do lose teeth, can I have implants? Okay. The answer to that at the moment is that we think yes, okay, but there hasn't been a huge amount of research into this. But at the moment we think yes, probably can, particularly as you move into adulthood and hopefully the intravenous cumulative dose of bisphosphonates may have reduced, then yes, but certainly your dentist would need to know about it. One of the things that we often talk about when we're treating patients with bisphosphonates is having bisphosphonate holidays. The research behind this isn't overwhelming, but we often, if we're going to take a tooth out or if you're going to have an implant, we talk about stopping the bisphosphonates for a period of months before placing this kind of thing. So it has to be planned, and you certainly need to be working with a dentist who has knowledge and understanding of bisphosphonates. Can I have orthodontic treatment? Is the other big one that people ask. Can you have orthodontic treatment if you have osteogenesis? Can you have orthodontic treatment if you have bisphosphonates? I know of many orthodontists who won't touch patients on bisphosphonates. Can't have it. You're on bisphosphonates. Yeah, you can. Okay. There is some evidence that teeth move a little bit slower, but they will move. You can still have orthodontic treatment if you're receiving bisphosphonates, okay? But the orthodontist needs to know about it. They may have to alter the forces that they're using. And certainly if you need extractions as part of that orthodontic treatment plan, then we need to know about it so that we can plan the timing of your extractions, maybe think about a bisphosphonate holiday, okay? You can have orthodontics, okay? If you've got dentogenesis, it gets a little bit more complicated still, because common braces such as these, where they're bonded onto the teeth, okay? One of the problems, just notice that little arrow doesn't show up. One of the problems with or conventional braces, fixed braces, is that if you attach those braces to teeth that have got dentogenesis, when you take the braces off, so will most of the enamel come with them. Okay, so it's a big concern. You attach the braces, it'll chip the enamel off. If you're an adult, you may already have paid a lot of money to have veneers and crowns, and it's going to damage those as well. Okay, one thing that orthodontists are starting to look at is whether, if you do want straighter teeth, whether or not you may possibly be able to have what we call clear aligners. The big ones in the market are called Invisalign, okay, but we call them clear aligners. And this is using them to basically a series of different types of braces. One is used after the other. They're rigid and they don't quite fit, okay? So when you put them in, they don't really want to go in, okay? But over time, your teeth move to fit them. And once they've fitted that aligner, the next one arrives, and you put that one in, and that moves the teeth again, okay? Beware, though. Clear aligners still need a dentist and ideally an orthodontist to be checking what is happening to fit them. Sometimes they also have to put some little attachments to the teeth to make them work properly as well. You will see in the press now do-it-yourself clear aligners. The big one on the market is Smile Direct out of the US, okay? Please, please, please do not be tempted, okay? They will save you a lot of money in the short term, but could cost you an awful lot in the long term, okay? Do-it-yourself clear aligners, I mean, you wouldn't do many other medical conditions by yourself, so please don't do clear aligners, yeah?
And they're all produced overseas, is that right?
Mostly. Yeah, produced overseas. Sorry.
On that one, sorry, I was made a splint. I don't know if it will.
Yeah.
But with the limited mouth opening, I was so afraid of wearing it because I do know of a child, not with OI, who aspirated a splint and actually passed away.
Yeah. Mm-hmm.
So I couldn't wear the splint.
Mm-hmm.
So I think just mentioning that there.
Yeah. Mm-hmm. It certainly is a concern. Yeah. Mm-hmm.
So yeah, it was something I didn't do.
Yeah.
It was made by someone at the dental hospital. So it was just
The question of possibly choking on a splint is an issue, but it would be unusual ever to choke on one of these types, particularly if it's been made by a dentist. They actually click in very well. They're actually quite hard to get out. You know, you've really got to get your fingernails underneath them. Yeah. No, they choking wouldn't, that wouldn't be one of my concerns if it's been made properly. The concern with the do-it-yourself, okay, is that you're actually taking the impression by yourself. Now, you haven't been trained how to do it, you don't know what you're doing, and therefore the likelihood is that it's not going to fit properly. Okay, choking wouldn't be a major concern. I can understand your concern yourself, but it wouldn't be a major concern of mine. But it is just another reason why, unfortunately, you do need to think about going to somebody who knows what they're doing. Mm-hmm. Just for the last few minutes, because I don't want to hold up your lunch, prevention. Okay, prevention obviously is better than cure, and that means you have to go along for regular dental care. Okay, unfortunately, Medicare doesn't think that our teeth are part of our body, and therefore, as far as Medicare is concerned, teeth are something that you have to pay a fortune to look after, and many people just don't have that kind of money, and therefore it goes down on the low list of priorities. Okay. The good news is, if you've got dentogenesis and you're at least up to the age of 26, there is something called the cleft lip and palate scheme. Okay, it was a Medicare scheme initially set up for cleft lip and palate, now it covers a host of many other conditions. A few years ago, dentogenesis imperfecta was added to that list. Doesn't help a huge amount except for orthodontics, but it will pay a certain amount towards such things as dental examinations and cleaning. Okay. The other thing I would definitely recommend that you do, if you haven't already done this, as you're looking into your NDIS funding, is make sure they know. Say, look, I have osteogenesis. It is vitally important that I maintain a healthy dentition, and therefore funding for regular dental care needs to be part of my NDIS funding. So advocate for that and say that we need this so that we can afford to pay for it. One of the things I'm looking into at the moment in transition, and I have no idea if this will happen, is whether or not we can try and work out with at least many of the patients in transition a way of trying to gain them access to the public dental services. Because as a child, you're entitled to free dental care. Once you hit 18, you know, you've got to win the lottery. You know? So why is it that at 18 you get free dental care? Beyond that, you've got to pay a lot of money, and it's one of the things I'm hoping that we may be able to get some movement on, is looking at a way of trying, at least in transition, to help with the funding. Very simple, regular, preventive dental care. Make sure you disrupt and remove all that plaque on a regular basis, okay? Getting in there twice a day, good old toothbrushing, okay, but also flossing as well, okay? Those bulbous crowns with DI, that chipped and broken enamel does tend to be a plaque trap. Get in there with your toothbrush, get in there with the dental floss. I really don't care which kind of toothpaste you use, so long as it's a fluoride toothpaste, okay? If you have had issues with a high rate of decay, then you may want to consider using one of the very high fluoride toothpaste, such as fluoride Colgate Nutrafluor, okay? But otherwise, just make sure it's a good quality fluoride toothpaste, and having spent that money on that toothpaste, don't go and wash it down the drain. This is true for anybody, not just if you've got OI or DI. When you finish brushing, a good swish around and spit out, but do not rinse, okay? Leave that little bit of extra toothpaste in there, your own natural little fluoride mouthwash for an hour or so, okay? Stop grazing. No amount of brushing will brush away a poor diet, okay? So stop all that grazing between meals. Try and limit your food intakes to 5 times a day, okay? Breakfast, morning tea, lunch, afternoon tea, and dinner. Nothing in between except water. Eliminate all that snacking. Sip on water. Do not, for God's sake, go and sip on anything like Coke, okay? To me, one of the worst things ever invented was moving Coke from cans into screw-top bottles that people can sip away on all day, okay? Sipping, snacking, terrible for our teeth. And avoid all snacking after the last meal, okay? Read the labels, okay? And remember that it's not just sugars. They'll hide sugars under all sorts of weird names on labels. Read the labels and get an idea of what you're putting in your mouth. Okay, I don't know how well that shows up, but that's an indication of the cubes, sugar cubes in each of those drinks. Milkshakes, Coke, energy drinks.
That's the one on the left side that looks incredible.
Yeah, it's just, you go down to, and have your milkshake. It's pure sugar, okay? Just get an idea of what you're putting in your mouth. Even the stuff we think is healthy. What could be wrong with raisins? It's fruit, but it's concentrated fruit. Once you concentrate it down, you concentrate the sugars, and it sticks like mad to your teeth. So its clearance rate is very slow. It can stay stuck there on your back teeth for ages. And just look at the amount of sugar in a handful of raisins, okay? Just to finish off, things have improved. This is a genuine advertisement, absolute genuine advertisement. This young 11-month-old, and he's not one of our youngest customers yet, okay? I mean, it really can't imagine how they ever thought it was appropriate to put 7-Up in a baby's bottle with milk. So we have improved, times have changed. Finally, if you would like any more information, good information. This is mainly about protecting baby teeth and looking after baby teeth, but it's good advice generally for looking after our teeth. Very good video produced by the ADA New South Wales Health called Protecting Tiny Teeth. If you just Google that, you'll find a link to the video. It's free to watch. Very good, produced by a very good friend of mine, a special needs dentist, Peter King, up in Newcastle. Excellent thing to watch. Very good, valued advice. Now, just to prove that we all have our genetic crosses to bear, I'm as deaf as a doorpost. I'm more than happy to take questions, but if you have got a question, please shout. Yeah. In fact, I might have to come all the way over there, because otherwise I won't hear. Yeah.
Hi, sorry for my English.
Yeah.
I'm trying to explain. I'm a mom to an 8-year-old son,
Yeah.
type 5. Now, he has lost 8 teeth. Not all of them, as in new, came out though. As I was searching, I have found that there's official documentation from Montreal, which I do have on my emails, and that it's a thing for specifically type 5 to have a missing teeth. Now, with his smile, just missing one here, it's not the most amazing thing. And I was thinking how we fix it, and as well, when is the best time
Okay.
for it to
So
fix?
at 8, he's lost 8 teeth. I presume the top 4 and the bottom 4. So that's normal for 8. Okay.
Missing the one.
Yeah, so that is quite normal. What we call the lateral incisors, that's the teeth either side of the middle ones, often don't come through until 8 anyway. So at this stage, it would be impossible to say that he's missing the teeth. What he needs is an X-ray to actually tell you whether or not those teeth are there.
This month,
Hmm?
which we're planning to do this month.
Yeah,
That's it.
yeah. So get
And
an
now
X-ray and
that
find out.
the necrosis as well, I'm thinking if we gonna fix it generally or just better leave it as it
It
is.
depends on there's a lot of ifs and buts there. If an single incisor is missing, depending upon other factors, the relative size of the teeth, whether or not there are other teeth missing, we either look at what we call maintaining the space for the future, or probably more commonly, we try and encourage the other teeth to come through and actually move to take that space up. So in the long run, there isn't a gap. But it's a lot of individual features for the child that you have to look at. So you need, whereabouts do you live? In Adelaide, okay. So I would be looking to link in with the paediatric dental unit, probably at the Women and Children's at Adelaide, where they do have paediatric dentists who would have a good idea, and working with orthodontists as well as to how to manage it if there is a tooth missing. Yeah. Right.
I'm also from Adelaide.
Oh, hi.
Hi. And our daughter
Yeah.
sees who used to be the head of paediatric dentistry at the Women's and Children's. She doesn't have DI, seemingly, she's type 4. He's looked at them, no DI. Seen her x-rays, no DI. My husband has the same genetic mutation. His teeth crack and chip and fall out and do all sorts of things. So the thing is, when her teeth come out and we put them aside waiting for the tooth fairy, within 48 hours, they just split clean in two. There was no crack there beforehand, they just split clean in two, and it's happened with 95%,
Yeah.
just like popcorn, with 95% of them. And when I showed this to our dentist, her dentist, he said, I've never seen anything like that before.
Yeah.
And then when I asked in our OI parents group and I showed them a picture of that, a few put up their hand and said, oh yeah, that's my child's, all of their teeth do that. They just split clean in two as if you've just carved it with a bandsaw.
Yeah.
Do you know
A
anything about
possible
that?
reason for that is that once the teeth are out of the mouth, they will desiccate. And as they desiccate, you can find that you'll get a difference between the elasticity of the dentine and the enamel. Okay?
Yeah.
But one interesting thing, if we go, I know I'm conscious of the time, but if we go back to look at that work that was done at the Karolinska, sorry, I don't really know this. One of the things that they noticed was that some patients were deemed not to have dentogenesis imperfecta clinically, but it was noted histologically. So that means that in the mouth they didn't have DI, this slide here, but histologically, if you put the teeth under a microscope, they did. Okay. Now, I'm hesitating to say any of this because I'm in front of Professor Salence and I'm not a geneticist. But Generally speaking, conditions such as this have what we call incomplete penetrance, so they don't always show. So the fact that your husband has apparent DI and your daughter's teeth are splitting once they come out would suggest to me that probably that mutation does have as a component of it DI, but it's expressing itself differently in your daughter. Okay, so it's not the level of penetrance is such that the expression isn't as severe. I can't say for sure, but my gut feeling would be that if somebody had to look at those teeth under a microscope, they would potentially find evidence of DI. Yeah, I don't know whether Professor Salens, whether you'd agree with that, but that would be my feeling.
Sally,
yeah.
As you know, you can look in a mouth and
Yeah.
you can see 8 teeth, and
Yeah.
3 you absolutely
Yeah,
see.
yeah. So
And
my
then 5 teeth,
yeah.
you know, and you pull one of those out and
Yeah.
histologically.
Yeah, so my suspicion is she probably has it, but clinically you can't actually see it. Yeah.
The question is, if you're a purist, is the change in the teeth DI or just the microscopic change which
Yeah.
indicates the dysplasia?
Yeah.
See, whereas, you know, the picture,
Yeah.
which, you know, historically is several hundred years old,
Yeah.
that's what's called DI, though,
Yeah.
not the histologic change.
Yeah.
The histologic.
So I guess actually the reason I'm asking is because it's when they dry out after they've been out of the
Yeah.
mouth. So if she has a cold and she's mouth breathing for, you know...
They don't dry out to that. It's the whole loss. It's the death of the tooth, basically, and all the tissues dying out. So certainly if she started to see anything chip and break with time, then that would be an indication. Yeah. Right. Oh dear, lots of questions.
I've just been told I can't go to my dentist to clean my teeth. I've always had a dentist who knows me for 70 years because he had an audit. Because he had an audit, because I was a family member, he wasn't charging me for cleaning my teeth. It would cost him $10,000. So I now have to go to, this is for the older people, he said, go to your health fund provided dentist, which is Bupa, and I luckily have one pretty close to home. Get 3 cleans a year, but if anything's major, come back to me. Now I can get those 3 cleans on my highest level health fund for $50. I might be wrong, but people, older people, have your high cover. The government's not going to give it to you. Use your healthcare fund. Just for the cleaning, even if it's just for the cleaning and 3 years, times a year, you can get that covered by your fund if your healthcare covered. That at least keeps your mouth clean.
Yep.
One final question, sorry, just going to full rank.
Several people have asked how many people in Australia have had, with OI, have had complete implants.
Oh, there's no way I could answer that question. Yeah. Oh, we have one there. Yeah, I wouldn't have a clue, to be honest with you. Yeah, I wouldn't know.
Okay, thank you.
Yeah.
One.
Just
Yeah.
quickly, I get Botox into my TMJ,
Yeah.
and I've had physio because I had an underbite. I thought
Yeah.
that might be an idea for others who may need it. I have DI. Is that, do you think okay, considering our collagen?
Well, what do you call the underbite is what I was saying, that is a result of the top jaw. Anatomically, the top jaw tends to be smaller than the lower jaw, okay? So it's what we call a class 3, bite, which is a bite like that. Provided it's not causing any problems, then there really wouldn't be an issue with it. About the only reason for putting in Botox, it doesn't go into the joint, actually goes into the muscles around the joint, is some people grind excessively. But I'm not a great fan of Botoxing the muscles that we use for eating unless there is a very, very good reason for it. There's a lot of reasons for that which I don't really have time to go into, but it's not something I would recommend unless there was a very good reason for Botoxing those muscles.
Can I just make a comment?
Yeah.
65 odd years ago, take the teeth out because the enamel's going, shove the dentures back in, and they're still there.
Yeah, I mean, I do have people say that, but I would never ever recommend losing our teeth for dentures. Yeah, it's, yeah.
Thank you very, very much, Sally, for coming along. Bag of goodies for you, which have actually fallen over. So
Oh,
not
wow.
so good for your teeth.
Oh, they might not be good for my teeth, but it's very good for my mental health.
So thank you very much for coming along. I really,
No
really
problem.
appreciate it. And please, if you can join us for lunch, that would be great. Everyone, what we have now is we do this at every conference, and it's something that we always look back.
How are you doing?